All right. Good afternoon, everyone. My name is Haley Aka, Associate Vice President at the Health Policy Institute of Ohio. Thank you so much for joining us for our webinar titled Tobacco, Alcohol, and Health: Implications for Future Cannabis Policy. If you are new to us, HPIO is an independent, nonpartisan, nonprofit research institute. Our mission is to advance evidence-informed policies that improve health, achieve equity, and lead to sustainable healthcare spending in Ohio. I'd like to thank our core funders who advance our mission with an investment in all of our work. And I'd also like to thank the sponsors of the 2022 Educational Event Series. Thank you all for making today's webinar possible. We encourage you to tweet throughout today's webinar using the hashtag HPIO Forum. We love engaging with you all in this work and would love to continue the conversation over there on Twitter. If you have questions for our team as we present today, please type those into the question box. We'll be taking questions at several points during the presentation, and we'll read as many as time allows. So at any time a question occurs to you, feel free to type that into the question box. I want to let you know that today's presentation slides and the briefs that we'll be discussing are all posted on our website. If you go to hpio.net and click on events, you'll see today's event and all those resources listed for you there. Thank you so much again for joining us. My name again is Haley Aka. I'm here with my colleagues, Amy Bush-Stevens, Jacob Santiago, and Lexi Charakos. And we're going to look through each of these briefs today. We're looking forward to sharing some of our recent analysis with you on tobacco, alcohol, and cannabis. This is how we'll be spending our time together this afternoon. Amy is going to get us started with some context. Jacob will then walk us through the health impacts and disparities in tobacco use that we see in Ohio, as well as some strategies for us to improve our outcomes. Lexi will take us through the alcohol impact section, and then Amy will be back to share about how the decades of research that we have on tobacco and alcohol policy can inform future cannabis policy decisions. So as I mentioned, we're going to pause for questions at several points throughout today's webinar. So as questions occur to you, feel free to drop those in the question box. I'll be monitoring those as my colleagues present. And with that, I will turn it over to Amy to get us started.
All right, thank you, Haley. Good afternoon, everyone. Today, we are going to be focusing on tobacco, alcohol, and cannabis, but I'm going to start us off with some data on the big picture of health and well-being in Ohio and the role that addiction plays in driving poor health and early death in our state more generally. But first, I will see if I can advance the slides. Always a challenge. All right, there we go. In June, we released a data snapshot that looks at deaths among Ohioans ages 15 to 64. We were interested in looking at this because we kept hearing from policymakers and the media about how difficult it is for employers to fill open positions. So we wanted to know, to what extent is poor health and premature death contributing to the workforce shortage? So we looked at data from the Ohio Department of Health to answer this question, looking at mortality data from 2007 to 2021 from the Public Health Data Warehouse. What we found is that working age Ohioans are dying at a much higher rate than they were 15 years ago. And these deaths are mostly preventable and have a tremendous impact on Ohio families and communities. And the trend also negatively affects Ohio's economy and businesses. So looking at the numbers on this graph here, you can see in 2007, there were about 25,000 Ohioans between the ages of 15 and 64 who passed away, and that increased to about 39,000 in 2021. That's an increase of 51%. And if the number of deaths had remained constant from 2007, about 58,000 fewer working age Ohioans would have died. This graphic compares changes in deaths for 3 different age groups. So we have children 0 to 14 on the left, and then in the middle is the working age population, and on the right are older adults. And the gray arrow shows the change in the size of the population for the age group to give some context for the change in the number of deaths. And the trends that we see here for children and older adults are not necessarily surprising, because the amount of change in the number of deaths was similar to the change in the size of the population overall. But the trends for the working age population were very surprising and troubling, because we see a divergence there. So while the number of folks in that age group declined slightly during this time period, the number of deaths increased by 51%. You may be wondering if COVID was driving this trend. To my next slide here. Whoop, there we go. And COVID definitely played a role, but it was not the main factor driving this trend. In 2021, 13% of the deaths of working age Ohioans were attributed to COVID. So it was the 4th leading cause of death for this age group. And note on this table that unintentional injuries was the largest leading cause of death for this age group. And that includes several subcategories, and unintentional drug overdoses was the biggest one within that category. So the bigger question is why? Why are we seeing these trends, and what else is contributing to this problem? And this chart here helps to explain the trends. It shows the percent change in the leading causes of death for working age Ohioans. And the biggest increases we see here were for unintentional injuries and chronic liver disease and cirrhosis. Also big increases for homicide, diabetes, and suicide. Addiction is clearly an underlying factor driving these trends. The largest cause was the unintentional injuries, and the biggest one within that is drug overdose deaths that we know are now being largely driven by fentanyl. And we've done a lot of work on overdose deaths specifically that's in our Addiction Evidence Project section of our website. So I'm not going to focus on overdose deaths today, but encourage you to check out that information if you want more detail on those trends. We also see here a prominent role for alcohol, so chronic liver disease, excuse me, and then also motor vehicle crashes, which is in unintentional injuries. Those are often alcohol involved. And then tobacco also plays a role, particularly in respiratory diseases like COPD, but also, of course, contributes to heart disease and stroke. In order to improve health in our state, it's critical that we do more to address addiction. This is from our health value dashboard, and it shows how Ohio ranked compared to other states. And you can see that we were in the bottom half of states for these metrics related to addiction and the topics that we're going to be discussing today. And if we zoom out further, we see that Ohio ranks poorly on health value overall, meaning that Ohioans are living less healthy lives and spending more on health care than people in most other states. So we thank you for being here today to talk about tobacco and alcohol, because those are major factors in this picture. And I'm sure many folks on the call are doing lots of good work to reduce tobacco and excessive alcohol use in our state, which is so important to get us to better health value. Now we're going to transition to focus on the 3 policy briefs that we released in December of 2021. We're going to start with tobacco, and then we will move on to alcohol and lessons learned for cannabis. And so I am going to turn it over to Jacob.
Thank you, Amy. I will see if I can. There we are. As Amy said, I'm going to be highlighting some information around the impacts of tobacco use disparities, and some strategy examples from the Tobacco Health Impacts Brief to help level set and tee up the conversation on cannabis policy. Here are the 3 key findings from the brief. Reducing tobacco use and nicotine dependence is a powerful way to improve health, achieve equity, and reduce healthcare spending. Systemic barriers to health, including poverty, discrimination, and targeted marketing of tobacco products, drive trends and disparities in tobacco use. And public and private partners can implement proven strategies to protect communities and keep young people from becoming addicted to nicotine. As many of you are aware, there are several health impacts of tobacco use and secondhand smoke exposure across the lifespan, including low birth weight and preterm birth, and incidence of cancer, COPD, and other conditions and diseases. And as a result of smoking, over 20,000 Ohioans die each year. These impacts on health also affect healthcare spending. About 20% of Medicaid spending specifically is attributable to the use of combustible and e-cigarettes. And overall, the total annual healthcare cost of cigarette smoking to Ohio is approximately $6.8 billion. To reduce the negative impacts of use and exposure, several recent changes in tobacco policy have been implemented, including Tobacco 21 and bans on characterizing flavors of tobacco products. And Medicaid is also working to reduce tobacco use. For example, Ohio Medicaid covers all cessation medications and services without requiring co-payments. Because of these policies and other efforts to prevent tobacco use, we have seen a substantial decrease in reported use of tobacco products, specifically among high schoolers in Ohio over the past decade. In 2019, 4.9% of youth reported using traditional cigarettes. However, in the same year, 29.8% of youth reported using e-cigarettes, confirming what many already know about changes in tobacco use patterns among youth in recent years. Still, several groups of Ohioans, including youth who are lesbian, gay, and bisexual, Medicaid enrollees, and Ohioans with disabilities, are all more likely to use e-cigarettes, combustible cigarettes, or both, more often compared to Ohio overall. These disparities in tobacco use are signals of environmental factors that do not support good health. Drivers such as marketing of products, discrimination, and trauma and toxic stress have all contributed to increases in tobacco use and disparities. Now let's explore some of these drivers. Advertising by tobacco companies has played a significant role in increasing tobacco use. For example, companies heavily market menthol cigarettes in predominantly Black communities through magazines and ads in neighborhoods. Menthol cigarettes are easier to smoke because of their ability to negate the typical burning sensation associated with inhaling smoke. And menthol also chemically interacts with nicotine, increasing nicotine's effect on the body, making mentholated cigarettes harder to quit. Marketing also heavily targets youth and young adults, specifically e-cigarette marketing. E-cigarette marketing plays on similar themes as traditional cigarette marketing has in the past, frequently including flavors, imagery, and positive sensations such as satisfaction that appeal to youth. And advertisements have also emphasized the health benefits of e-cigarettes compared to traditional cigarettes. Several additional factors contribute to tobacco dependence, including adverse childhood experiences, or ACEs. ACEs, including abuse, neglect, and household challenges like substance use in the home, contribute to toxic stress and trigger the body's fight or flight response for long periods of time, harming the body's endocrine, nervous, and immune systems, leading to health issues down the line. Ohioans who reported experiencing multiple ACEs were more likely to report current smoking than Ohioans who reported experiencing no ACEs. Furthermore, Ohioans with low incomes are also more likely to report experiencing multiple ACEs. And while overall smoking rates have declined over the past 3 decades, this has not been the case for people with low incomes. In 1995, Ohioans earning less than $15,000 a year were almost 1.5 times more likely to smoke than Ohioans earning $50,000 or more. By 2020, that gap had grown. Ohioans with low incomes were almost 3.5 times more likely to smoke in 2020 than Ohioans with higher incomes. Stress, including experiences of poverty and trauma, pushes people to find ways to cope, including tobacco use. And people often cite stress as the reason they continue to smoke or relapse after quitting. On the screen now is a pathway showing the connection between nicotine and stress. Nicotine use stimulates the release of dopamine in the brain, leading to a feeling of pleasantness and calmness. Nicotine withdrawal sees a drop in dopamine levels, leading to symptoms of stress and anxiety, driving people to want another cigarette to bring back that pleasant and calm feeling. This connection between stress and nicotine helps explain the high rate of tobacco use among people who, in the past month, reported experiencing 14 or more days when their mental health was not good, compared to people reporting 13 or less poor mental health days. People with behavioral health conditions who smoke do so more frequently, face extra challenges in successfully quitting despite wanting to quit, and die almost 15 years earlier than people without a behavioral health condition who do not smoke, signaling a need for balance between harm reduction and tobacco cessation and prevention in mental health treatment. It's also important to note that lesbian, gay, and bisexual youth in Ohio and Ohioans with disabilities are more likely to experience poor mental health and report current smoking. Discrimination, including homophobia and ableism, is a primary driver of these outcomes. There are many ways that public and private partners in Ohio can reduce tobacco use and reduce disparities in tobacco use. Many cities and towns across the state, including Cincinnati, are implementing retail licensing laws to enforce Tobacco 21. The Department of Health's Tobacco Quit Line has implemented tailored services for people with behavioral health conditions and has been exploring ways to improve the cultural competence of its services. And both CVS pharmacies and John Glenn International Airport here in Columbus have stopped selling tobacco products on their premises. We will now pause and take a moment to answer any questions.
Thank you, Jacob. Yeah, this is a great time to ask any questions that you have. A couple questions have come in, but they were easy ones that we could answer in the chat. Things like, will the slides be posted? Yes, the slides are actually currently posted. If you go to hpio.net and click on events, you'll find today's event. And there you'll see the slides for today's session and the briefs that we're covering today as well. This is a good time though, if you have any additional questions for Jacob, you can go ahead and ask those. And also take a little stretch, stand up. I'm standing up while I speak with you all today. It's a good thing to do. All right, well, I will continue to monitor the question box and Jacob will let you know if any come in for you. But in the meantime, I think we can move it along to Lexi and the alcohol conversation.
Hi, everyone. Sorry, I'm having trouble getting my camera to start. Thank you. All right. So thank you, Haley and Jacob, and thank you all so much for being here today. I'm very excited to talk to you about our recent publication, The Health Impacts of Alcohol Use in Ohio. And like Haley said, all these briefs can be found on our website. These are the 3 key findings from the brief. Reducing excessive alcohol use can improve the health of Ohioans. Pandemic-related stress, discrimination, and targeted marketing can drive disparities in alcohol use. And there are strategies public and private partners can utilize to protect communities from the harms of excessive alcohol use, especially to keep young people from becoming dependent. Just like Jacob talked about with tobacco, the health impacts of alcohol can occur across the lifespan. Beginning with pregnancy and in the peri and neonatal life stages, we know that alcohol use during pregnancy is linked to fetal alcohol spectrum disorders. This can lead to low body weight in the infant, sleep problems, and learning disabilities later in life. Alcohol use during adolescence has negative consequences on the developing brain and can lead to poor academic performance, mental health problems, and heavy drinking throughout the life course. Alcohol use in adulthood poses an increased risk for many health consequences, including cardiovascular disease, cancers, liver disease, immune suppression, and learning and memory problems. Alcohol use also significantly contributes to violence, motor vehicle crashes, and other injuries. The CDC recently reported that excessive alcohol use contributes to 1 in 4 injury deaths nationally. Yeah, despite the risks that we know and the health impacts that we know alcohol has across the life course, most recent alcohol policies have been focused on expanding access to alcohol across the state. Municipal corporations and townships are now allowed to establish designated outdoor refreshment areas, or DORAs, which have increased in number across the state. And policy changes around vendor permits to sell alcoholic ice cream have also expanded alcohol access. During the pandemic, House Bill 669 was passed, which allows bars and restaurants to sell to-go alcohol beverages in sealed covered containers and exempted delivery of these to-go drinks from open container laws, further increasing access. And while increased hazing penalties for coerced consumption of alcohol on college campuses does represent a recognition of the dangers of alcohol overconsumption, these policies have steered the focus away from prevention and treatment of alcohol use disorder and toward expanded access and harsher consequences. As this access has expanded, so too has the alcohol consumption trend, which has been increasing steadily during the past 2 decades, which is the graph that I'm showing here. This sharp increase in the amount of liquor sold in Ohio from 2019 to 2020 may have been exacerbated by social isolation and stress during the pandemic. Research indicates that people who already drank heavily prior to 2020 were more likely to increase their alcohol consumption during the pandemic. Caregiving responsibilities, stress, depression, and anxiety were also associated with increased substance use throughout the COVID-19 crisis. And sadly, this trend has also extended to alcohol-involved deaths, which have increased dramatically over the past decade. Alcohol-involved deaths are defined as 100% alcohol attributable, including both chronic and acute causes of death. And it's considered a very conservative estimate of deaths related to alcohol, as it does not include motor vehicle crashes or other injuries. This trend in Ohio is unfortunately very consistent with national increases in deaths related to alcohol, where drinking contributes to an estimated 95,000 deaths annually and is listed as the 3rd highest cause of preventable death in the nation. I'm just calling this out again for you to emphasize the data that Amy showed you earlier. Death from chronic liver disease and cirrhosis is the 7th leading cause of death of working age Ohioans from 15 to 64 in 2021. and it has increased 74% since 2007. And keep in mind that liver disease and cirrhosis is something that takes many years to manifest itself. These deaths represent decades of untreated alcohol use disorder. And given the increase in alcohol sales and access, this trend is likely to get worse in the coming years without intervention. Going upstream now, I'd like to talk about the Ohioans that are most at risk for some of these outcomes that we can measure, such as binge drinking and heavy drinking. The definitions are listed below the titles on the slide. The expanded access to alcohol has reflected in recent trends in excessive alcohol use across different age groups. The most notable increases in adult binge drinking from 2010 to 2020 were among adults aged 55 and up. At the same time, there has been a clear shift in drinking patterns among men and women. While binge drinking remains more common among men than women, the percent of Ohio women who reported binge drinking during the past month increased 15% from 2010 to 2020, compared to a 17% decline for men during that same period. Increased psychological stress linked to factors such as pandemic-related isolation, again, these caregiving responsibilities, as well as domestic violence and targeted marketing, have likely contributed to the increased drinking among women. Additionally, these experiences of discrimination, like familial rejection, bullying, and harassment, can also increase stress and negatively affect mental health. And often with youth, it especially can contribute to the use of alcohol to cope. In 2019, young people who identified as lesbian, gay, and bisexual in Ohio were over twice as likely to report feelings of sad or hopelessness almost every day for 2 or more weeks than Ohio youth overall. And that same group was more likely to binge drink than Ohio youth overall. Additionally, people with poor mental health and people without insurance are also more likely to drink more heavily, and this is largely driven by toxic stress. As I said earlier, alcohol use disorder and mental health conditions are often co-occurring. Stress and trauma, among other environmental factors, can lead to the development of both mental health conditions and substance use disorders through physiological changes to the body. As a result, those diagnosed with alcohol use disorder were over twice as likely to have major depressive disorder than those without alcohol use disorder. And people with mental health conditions will often turn to alcohol as a form of self-medication to cope with toxic stress. In Ohio, people who self-reported 14 or more days when their mental health was not good were more likely to both binge drink and heavy drink. As I mentioned previously, some of the primary drivers of alcohol misuse are discrimination and toxic stress, but alcohol marketing, just like tobacco marketing, often targets young adults especially. And because of perceptions of alcohol-related peer behaviors and attitudes are the primary motivator for alcohol use, marketing via social media is especially effective at encouraging young people to start drinking. Alcohol retail density, which refers to the number of alcohol selling outlets by area or population, can also particularly impact communities of color. A national study found that urban census tracts with higher proportions of poor, Black, and Latino residents had a greater density of alcohol retailers. Restrictions on alcohol retail density through licensing or zoning processes are associated with lower rates of consumption, violent crime, underage drinking, intimate partner violence, and child abuse. So reducing alcohol retail density can have a significant positive effect on the impact on the health of these communities and protect residents from disproportionate downstream harms. And then finally, here are some examples of effective strategies that are already being implemented across the state to reduce the harms, especially for young people, of alcohol overconsumption. Reducing advertising alcohol products at retail stores, enforcing laws prohibiting underage alcohol sales, and screening and early intervention in schools can reduce binge drinking and heavy drinking, especially in the most high-risk groups.
Thank you so much, Lexi. No questions at this time. Friends, if anything occurs to you and you'd like to ask our presenters anything, or you have thoughts or feedback, please feel free to share that in either the question box or in the chat box. Our colleague Nick Weislogel just posted the webinar link for today, which has all these briefs there if you want to go look deeper at anything that our presenters are sharing. That will let Amy get into the meat of this related to cannabis, future cannabis policy.
Okay, I'm back. Let's see if I can get my slide advancing powers back. Aha. All right. So as you have probably heard, there are efforts underway to legalize recreational cannabis in Ohio, and advocates are framing it as let's legalize marijuana like alcohol. So we thought it would be helpful to look more closely at what that would really mean to regulate cannabis like alcohol and tobacco. And so I'm going to be talking about our overview policy brief that talks about lessons learned from tobacco and alcohol and how we can apply those lessons to cannabis, and what policymakers need to keep in mind as they think about regulating recreational cannabis. Here are 3 key findings from this overview brief. The first is that we know what works to reduce tobacco and alcohol dependence, and you heard Lexi and Jacob talk about some of that. Tobacco and alcohol policies and outcomes have implications for future cannabis policy, and now is the time to set clear policy goals on legal drugs. 19 states currently have legal adult use or recreational cannabis. And so you can see on this map, dark green is legalized recreational and medical. The medium green is medical only. So that's the category that Ohio fits into. Light green is very limited medical exceptions, and then gray is still totally illegal. So as is often the case, Ohio not really on the cutting edge, but you can see this sort of dark green wave closing in on us. Here's a look at the current cannabis policy landscape in Ohio. In 2016 is when our medical program began, and in 2021, an expansion of the medical program passed the Senate. So that was Huffman's SB 261 that has not passed the House. There has also been a lot of activity on the recreational side. In 2021, the Coalition to Regulate Marijuana Like Alcohol started their ballot initiative process, and 3 bills were introduced in the General Assembly. And then in 2022, another recreational bill was introduced, HB 682, and then the ballot initiative got delayed until 2023. So this is the process for the initiated statute. It was initially supposed to be on the November 2022 ballot. However, as you may have heard, there was conflict over the signature gathering process, and then there was a lawsuit. So now this process has been delayed until 2023. So stay tuned on this. We know that leaders in the legislature and the governor are certainly not enthusiastic about legalizing recreational cannabis, but it's possible it could pass via the ballot initiative because there is relatively strong support in the public, according to polls. And if you want to learn more about the details of what's in the ballot initiative and all of the bills that have been introduced, we encourage you to check out this tool on the Drug Enforcement and Policy Center website, where you can really dig into the details on those. So that's the policy landscape of where we are with cannabis in Ohio right now. And now we're going to take a look at lessons learned from tobacco and alcohol that can be applied to cannabis. The first thing that we've learned is that easy access and low prices lead to higher consumption. So we know, thinking about cannabis, we know that well-designed access, price, and tax policies can be important. The second is that product types and marketing tactics change more quickly than public health data systems can monitor drug trends. So, think, for example, about vaping and youth. So vigilant monitoring and data collection are needed to stay on top of trends and to adjust policy as needed. The third here is that excise tax revenue has not been used for addiction prevention. Cigarette and alcohol tax revenue goes right into general revenue and is not dedicated to prevention or treatment. So in the future, we can think about making sure a portion of any marijuana tax revenue goes towards behavioral health. Number 4 is that designating a drug as legal may lead the public to assume that it's not harmful to health. So alcohol is generally perceived as being safe, but of course we know that it contributes to cancer and heart disease and other health challenges. So we need to make sure we have effective public communication about the risks and benefits of cannabis. Number 5 is that toxic stress and trauma play a critical role in drug dependence. So trauma-informed care and addiction treatment that's tailored to the complex needs of people who have experienced violence, poverty, mental illness are very important. And then number 6 is that a general one-size-fits-all prevention and treatment approach doesn't work for every Ohioan. So we need to make sure that we have culturally relevant prevention and cessation messages and services to counter the effects of things like aggressive marketing tactics that target communities of color, LGBTQ people, and other groups. And finally, the last lesson learned here is that an effective public health approach includes both prevention and harm reduction. So prevention, of course, is very important for deterring or delaying cannabis use for young people. And harm reduction can mitigate downstream effects of excessive use. And harm reduction includes things like avoiding policies that increase incarceration. So we need to keep all of those things in mind and in balance. So how do we put effective policies in place that limit consumption and eliminate disparities and mitigate harm? Well, luckily we have decades of research on what policies and programs have worked for tobacco and alcohol. So these are just a few examples. So when we look at youth access, we know that, that we have Tobacco 21 as an example. Enhanced enforcement of laws against alcohol sales to minor would be another example from that category. Looking at retail sales restrictions, things like tobacco retail licensing and regulations on alcohol outlet density are important. And then for public safety, examples are smoke-free workplaces and ignition interlocks for impaired driving. We can apply many of these same policy tools to cannabis. So we do have a place to start, a playbook and a set of tools that can be adapted for cannabis. Of course, cannabis is different from alcohol and tobacco, but there are still tools in the policy toolbox that can be used. And as we think about specific provisions in the ballot initiative and in the legislation that's been introduced, we should be clear about the policy goals of legalization. So we put this framework together to lay out what we see as potential goals from a health perspective. So protecting youth health and brain development, minimizing harms and protecting public safety. So this would include safe driving, promoting equity and justice. So this includes economic opportunity and decreased incarceration. And then finally, reinvesting tax revenue in prevention, treatment, and recovery. So putting these policy goals together with policy actions gives us a framework for analyzing proposed policy changes. So for each proposal, as we look at the ballot initiative, as we look at the legislation, we should be asking ourselves things like, what does allowing home grow mean for youth access and brain development? Or what does legalization mean for racial disparities in incarceration rates or for specific types of health outcomes or health priorities in our state? And would the proposed excise tax and allocation of tax revenues adequately support prevention and treatment? And what would be the net impact on our behavioral health treatment system, both in positive and negative ways? We close the policy brief with these 3 recommendations. So the first is to strengthen implementation of proven tobacco and alcohol policies. So some of those things that Jacob and Lexi talked about, really making sure that we're implementing those fully, because we still have a ways to go in Ohio. Second is clarifying policy goals for recreational cannabis, being really clear about what we want to see. And then finally, deploying effective strategies to achieve cannabis policy goals. And I'm going to turn it back over to Haley to see if we have any questions.
Thanks, Amy. We have one question that comes from Leah Bruno in Rep Weinstein's office. You know, they're working on this issue on adult use legalization, and they say that they get the question often about cannabis being a gateway drug to other substances. And so they're wondering, I mean, I know the work that we've done to date has not dove into this, but just this interaction between cannabis and other substances, and, you know, is there a positive or negative effect on other substance use, or how can we be thinking about substance use holistically while we're setting up cannabis policy?
Yeah, and that's, as we think about that policy goal of protecting youth, that's an important thing to think about. We do know from research that the younger an adolescent starts using substances, the more likely that they will go on to have a problem with addiction later in life. So preventing early use of any drug is important. In terms of the specificity of marijuana as the gateway drug to, and like connections to other drugs, we haven't done a deep dive on that research, but I think the general research applies, that just anything we can do to prevent or adolescent use in general, and particularly younger adolescent use, is very important for health.
That's great. AJ Godby in the chat noted that research has found that tobacco and alcohol tend to be the drugs of first use, not cannabis. So something to look into.
Yeah.
Thank you all.
Alcohol and vaping.
Yep. Tends to be what it is. All right. Well, we have 2 minutes left in our time. Feel free to drop additional questions in the chat or in the question box. If they occur to you, we can deal with those in the chat and make sure that you get your questions answered. I'm going to leave us with a couple of poll questions. Oh, a reminder again that our the materials from today are posted on the website. That link is in the chat for you. We hope that you find those resources useful. And I want to get to my poll question.
It's hiding.
There we go. Our first question for you is, how would you rate today's webinar? Alana is going to throw that poll for us. We're always looking for ways to improve these events and make sure that we're getting you the resources that are useful to you. So please let us know how you would rate this webinar. And if you have any particular feedback, go ahead and send that to us panelists in the chat. Let Alana pull that down when she's ready. Okay. And then another thing, the last poll question we'll ask is related to using this work to influence policy. Our hope is that our work is helpful to you in this effort to influence policy, to improve health and well-being in our state. And there are many different ways that you can influence policy, both as a private citizen and as a representative of your organization. And we have a few of these listed here. So with these in mind, how likely are you to use the information presented in today's educational event, in today's webinar, to influence the policymaking process. You'll note we have the option here that, not applicable, that your job does not involve influencing policymaking. That is a completely okay response. Thank you again for participating in today's event, for taking these polls for us. Here are some ways that you can stay connected with us. Look forward to seeing you at future events, and take care. Have a wonderful week. Bye all.